Okay, so trauma adaptations for positioning, okay? The main thing that you need to remember for trauma is if you can't put the patient in the ideal position, you need a minimum of 2 projections at 90 degrees from each other, often with the patient not moving at all. So notice in this case, the patient has their foot supported on some radiolucent sponges, and the cassette in the top image has been placed just under the plantar surface of the foot. What did they do to support the cassette? Who knows? They used stuff, okay? I've used pillows and towels and sheets and tape and anything that you can use to support the cassette. There are no special devices for supporting the cassette in random positions, okay? You may have them if you open up a book of radiographic equipment. You may find them, but no one's going to buy them for you. Yeah.
So I have like this. Well, I mean, this is in the ER setting, right?
Oh, you can do this. I've done this in urgent care settings.
Okay, because I have like this little thing that I used to hold up my tablet, like kind of like a little stand, but it's really, really sturdy. So if you were to get something like that, I mean, it's about the same size almost from the side.
Yeah.
So if you were to use it, you could use something like that to hold it up.
Yeah, so there are devices that are designed to hold the cassettes vertical, right? But there are no devices that are designed to adjust the angle of the cassette.
This one.
So you may have one, but not for radiography, right? And when they're used, they have to be able to clamp onto the cassette and not be visible on the image, right? So now again, you may open up a radiographic equipment textbook, or not textbook, a supply book, right? And you may look through and they're like, oh, look at all this cool equipment that you can buy for radiography suites, right? Nobody's going to buy it for your radiography suite. They're just not going to have it. I don't know why they even exist. Someone somewhere bought it, but it's not going to be in your room, unfortunately. So, if you've got something that will work, use it, right? But in almost every case, you just have to improvise your supporting, what you're going to use to support the cassette, right? You cannot use an X-ray tech, okay? You cannot use, and you should not use a patient guardian, okay? And you shouldn't use somebody who's non-radiographic personnel unless you absolutely need to, okay? You're going to try to use inanimate objects to support the cassette. One thing I will tell you is that if you don't have something to support the cassette when it needs to be placed vertically, such as this lower image, the calipers that we use to measure body part thickness, those can be used to support the cassettes. I've shown you guys how to do that before, where you use the caliper flat on the table, use the clamp to hold the cassette vertical, okay? And that can be done for vertical placement, but for horizontal, for any kind of axial placement of the cassette, you're gonna have to just figure out something that works. Stack some things, put it in the way, use tape, that kind of stuff. But importantly for this image, you'll notice the patient's body part is kept in the same position between the two images. One is taken AP, cassette placed under the plantar surface of the foot, and the central ray is projected down, perpendicular to the cassette. Okay, and the lateral of the foot is taken with the cassette placed vertical next to the foot, and the X-ray tube in this case has been brought to shoot cross table, across the width of the table. So what has to move? If the patient can't move, your X-ray machine has to move. Okay, that's the other option. Your X-ray machine have to move. So this requires adaptation of the CR angle and image receptor placement without moving the patient. If your patient can move, they should. But when you've got this patient with a likely, at least but likely trimalleolar fracture of the ankle, displaced, maybe even open, you're not going to be moving this patient around. They're going to be splinted, and they're not going to be in any condition to move with you. They're going to be on, medications that are going to keep them from really being able to cooperate with you. So yeah, adapt CR angles, adapt image receptor placement to minimize further injury or discomfort to the patient. Basically, you're working around them. Okay, they are fixed and you're working around them. Now that requires that your X-ray suite have some ability to work around people. Okay, some can't. Some X-ray suites cannot do that. Okay, so you may have some limitations on what you're able to do based on the type of X-ray equipment that you have. And you're just going to do your best, okay? But the rule is, and it will always be, 2 projections at 90 degrees to each other. So one frontal projection, as in the AP up top, and one lateral projection, as in below. You'll notice, those of you who have shot a foot before, that lateral projection is the wrong direction, right? Normally we shoot the foot from medial to lateral, right? With the foot on its side the other way. In this case, this X-ray beam is traveling from the lateral surface of the foot through to the medial surface. And it's the wrong direction, but you're still going to get the correct projection. You're still going to get the right projection, even though you're shooting the wrong direction. So this is what I mean by adapting. Some exceptions. You may have a barrier to achieving a true frontal or AP view and a true lateral view. You might have splints. You might have traction bars. Traction is when a body part is pulled on to keep the two bony fragments from jamming past each other and doing things like severing arteries and veins and importantly nerve fibers. So the bones are pulled apart and kept in traction. They're kept pulled apart so that they don't hurt, further injure the patient. Well, those are going to be big metal devices that are going to get in your way, and you might have some limitations to that. So if there is something that prevents you from achieving a true AP and a true lateral, even with it able to move the X-ray machine, you just get as close to that as you can. Okay, get as close to true AP and as close to true lateral as you're able. So notice this cervical spine study being done. We want to do it AP, but because of whatever is in here, probably behind the patient, there's some metal supports, and in this cervical collar, there's likely metal supports. And if you shot directly through, those metal supports would superimpose over the spine. Okay, and so in this case, they come in at an oblique angle. You notice the central ray here. If I can zoom in. The central ray is being brought at a kind of an off angle, right? More like an oblique plane, and you're not going to get a true frontal view. Okay, and you just can't. You get as close to that as you're able to. Okay. Our second principle of trauma adaptation. Initial long bone studies that require both joints to be demonstrated for each projection. So what they're saying is that the first image of this body part, when the trauma happens, you need to demonstrate both ends of the bone, both joints on either end of the bone. Okay. Now, if you cannot get them all on one image receptor, as I was talking about with Parrish, you need to take as much as you can, include as much as you can on one image receptor, and then gather another image of what you were not able to include, making sure there is some overlap between the first and second image. Okay. And again, wherever the trauma was, include that on the original, largest, most expanded image. Yes?
Do you think it's necessary to stitch those together, or do you just put them together?
If you have image stitching software, heck yeah. But a lot of times you don't have the image stitching software.
We had to stitch some skulls.
Yeah, so you're the stuff you get to play with in ortho, most places don't get to play with, like image stitching. It's not really common, but yeah, they don't come out great all the time. But if you have image stitching, so image stitching is exactly what it sounds like. It's the computer software's ability to connect two images together. Okay, so it's able to recognize anatomy and things like that and put the two images together. If you can, you do. If you can't, you don't. You just have them separate. Make sure there's always overlap between those first and second images. However, follow-up studies, right? If they had trauma and you were able to radiograph the entire bone, the follow-up study might only require radiographs of the actual injury site, or the joint closest to the injury site and the injury site itself. You may not have to radiograph the entire bony anatomy again for the follow-up. But always on initial evaluation, you need to include the entire bony anatomy for whatever the body part is, making sure that if you don't get it all on one image, that you include on a second image the rest. Okay. Trauma often involves what's called cross-table X-rays, or horizontal beam projections being the correct technical term. Things to think about with a horizontal beam. Okay. The main thing to think about is that if you lay the body part flat to the table, it will be at the very bottom of the image receptor. Okay. and you may actually disinclude some anatomy. You may actually cut off some anatomy if you don't actually take and support the body part. So in this case, this is a lateral, a cross-table lateral of a skull. Okay, limited text, don't shoot skull. So, but importantly, it's showing you a skull. It's cross-table lateral, and what's underneath the skull? A positioning sponge, right? So for my new people, these grayish colored sponges, they're called positioning sponges. I've been referring to them as I've been seeing them as radiolucent sponges. And what they are is they're sponges made of foam that doesn't show up on x-rays. So you can shoot x-rays right through them and they don't show up, okay? They don't show up in a way that takes away from the information, doesn't block anatomy. So yeah, you have to actually support the head, right? Normally, when we place body parts, flat to the receptor or up on the wall bucky, we're able to center that body part, right? But with her head laying laying on the table, we can't very well center the body part because the image receptor is going to be sitting on the table with their head. So we want to be able, if possible, raise that body part. You also saw that with the foot X-ray, right? There's radiolucent sponges supporting the foot. So we're not moving the foot around, but initially we had to support the foot on something. No, that's the wrong one. There. So good. Make sure there's some support for the body part. And remember that the beam diverges. The beam spreads out, okay? So if their head was touching the table, and if the beam didn't spread out, their head would be included on the receptor. Remember that the beam does spread out. And so that whatever the size of their head is going to appear larger on the image receptor, okay? Which means that if their head is flat to the table, their head is going to be projected off of the image receptor on the actual image, okay? So making sure that you support the body part so that, and you can see that, you can see it, you can see the shadow of her head, right? At least on the top image, you can see the shadow of her head. Notice that it's larger than the body part is, than the actual skull, her skull is. So keep that in mind. Make sure that the body part is centered well enough to where you can include the entire thing on the image receptor. That's often forgotten with cross-table projections. Trauma chest. There's more like, not necessarily trauma, but the patient can't come with you, okay? They can't get up, they can't move with you. They're in my urgent care setting, the most common thing that I've dealt with is people who are wheelchair bound, okay? And not just like regular wheelchairs. I'm talking about like the motorized wheelchairs, okay? They're not going to be able to get out of it. You're not going to be able to use the wall bucky, okay? Or the table bucket or any of that stuff, okay? Whatever you do, you have to do with them in their wheelchair, okay? Or with them in their hospital bed. And so chest x-rays need to be done with the patient standing, okay? If they cannot be done standing, we want to get them as upright as possible, okay? The reason for that is because in the chest, some of what we're looking for includes air and fluid levels, okay? And you may know that air likes to go up and fluid likes to go down, okay? So you want to put them, if they're supine, fluid spreads out and air spreads out in the supine position, okay? Laying down like that. So you won't get to visualize air fluid levels. Performing the study erect or semi-erect, seated up, as much as they're able, puts them into the position to where you can demonstrate air fluid levels. Now, importantly, you won't be able to do things like demonstrate accurately the size of the heart, but we understand that, and we just say, okay, well, that's taken out of the equation. Let's get as much information as we can about this with these images. But that's common. AP semi-erect is a good position for the chest x-ray if you cannot get them to stand up.